Here we are. Welcome to London, guys. Welcome to London.
Good morning. It's a great pleasure to be here. I thank Lorenzo for hosting the Televascular Games. Today is the 20th edition. It is on presence. Normally it is online. And so the main focus of the edition is to share the case, to discuss, and especially for the young trainees to have a second opinion. So can I have the slide? This is the case we share online. It is a 40-minute claudication on the right side only, no symptoms at all on the left side. You can see the very calcified iliac stenotic lesion. And so we asked, after a failed supervised medical therapy exercise, how to treat these patients. And so we did a survey, an online survey, and what we asked, here you can see the list of questions for our participants, and the first answer was about the site of treatment. Most of the participants decided to treat bilaterally, 73%, right side only in 27%. The vessel preparation was decided in 56%, so this is quite interesting because this is a new concept, the vessel preparation for iliac vessel. Regarding stenting or not, we can see that 92% decided to stent and 50% decided for a kissing iliac stent and 80% wanted an IVL alone. Regarding the type of stent, bare metal stent was the most picked up, and the cover stent in 33% of the cases. And if you look at the orange part with the cover stent, the most of them were balloon mounted, 80%. And if you look at the bare metal stent, 90% were balloon mounted. So the clinical case, here you can see now we start discussion, and so I invited Stefano to show with all of you the case in the details. So please.
Thank you, Emiliano. Good morning, everybody. And so after viewing the results of this survey, just with one picture, probably we'll ask you and we'll ask the moderator after the first angiogram, what is the ideal treatment for this patient? She is a female, so young female, 61 years old. After two coronary stent, 2 months later, we did this procedure, and the cardiologist performed the first angiogram from the pigtail from above, as you can see. So after the cardiac treatment, he performed the angiograms, and then he sent the patient to us. Of course, this was not a urgent patient, a claudicant with the 50 meters on the right side. We planned to do a CT scan. So this is what we do usually for iliac treatment. So this is the volume rendering. You can see just a stenosis on the right side. The patient had a tibial pulse on the left side. The duplex was triphasic on the left, monophasic on the right with probably 80–90%. So a simple calcified stenosis. The anchor-brother index was 0.6. So this was the CT scan, the axial view, and this is a sort of computed volume measuring of the calcium. The calcium was up there 30% of the volume between the bifurcation and the proximal common. So we had some concentric lesion, not severe lesion, just a single lesion at the proximal ostium, so typical, and then a fibrotic lesion in the middle portion. So it seems an easy case, spot lesion, calcified lesion, concentric with a sort of, in the middle was an eccentric, concentric plus eccentric, and these are the map of our lesion. So a lot of stenosis, probably 30–40%, not more, with left tibial pulse on the tibial pulse on the left side, and just with one severe stenosis, very, very proximal, so at the ostium. So what we planned and what we did. Of course, we like to do a puncture with ultrasound, and after the outpatient clinic, when we, of course, perform a Doppler scan, we repeat always the Doppler scan in the operative room, and we like the concept of EVUS. So we check always the flow before the treatment and during the treatment, after the treatment. So this was a monophasic flow, a direct but monophasic, and this is the first angiogram. So these are my colleagues from cardiology department. And this is the first angiogram. You can see the angiogram in loop. So you can discuss together after the first angiogram.
Thank you,
Please,
Stefano. So
Emiliano.
now we can start discussion, and I will ask Antonella to start with her opinion about this case. What will you would like to perform?
It's open?
Yeah, it's working.
It's working? Okay, perfect. Well, the location of the lesion is quite close to the aortic bifurcation, and actually on the CT scan, the plaque was extending up into the aorta. So most probably what I would think about is to go directly for a stent, at least what I usually do, and I would extend the stent into the aorta. So I would rather go for a kissing stent. And
So primary kissing stent.
primary kissing stent, yes. As I do not do any preparation if I can get through with the stent. So if I go through with a long sheath and I can pass the stenosis or the occlusion, then I pull back, I deliver the stent, I pull back the long sheath, and then if it's nothing happens, if I can do it, I don't do any kind of preparation. And then I would go for a kissing stent. There was a lot of calcium. There was also something at the CT scan, let's call it black, so maybe something that was quite a little bit more recent. I don't know if it could have been a risk of embolization, but so I rather prefer to use covered stent. Not exactly for a distal embolization, not in this case at least, but for the risk of rupture. The calcification was almost about, you said, 30?
80–90%.
Yeah. So the part of the artery that I can work on with my stent is very small, and so that's why I would maybe suspect a rupture. This might happen. Of course, the rate of rupture reported in the literature is about 1%, even less. But how many of you have reported your own rupture? I never did, and I had. So.
Which was the size of the vessel?
It was the reference vessel diameter was 8.1 millimeter.
So, which stent?
8.1 with a balloon expandable stent. I would have gone quite nominal, so nominal. 8 millimeter.
So thank you, Antonella. And please, can you comment, Kun, regarding this case?
Yeah, thank you very much. First of all, I would like to thank, I didn't have the opportunity yesterday to thank Lorenzo and the organizing team for the invitation and congratulate them with this fantastic setup. I'm impressed. Of course, it was a little bit of a surprise for me to be here in this session. I was not scheduled, but replacing another Belgian guy. And I am supposed to completely disagree with you, Antonella. And it is also easy because also in reality, I completely disagree. First of all, okay, passing is not an issue here. It's a stenosis. It's not so I think in terms of access and wire passing, no big deal. Vessel prep. Vessel prep, I've seen in the survey you had the choice between a regular angioplasty and then the intravascular lithotripsy. First of all, intravascular lithotripsy, there is no evidence at all in the common iliac. But okay, if it works in a common femoral or in an SFA, we assume that it potentially will work also in this kind of lesions, but always important to say, no evidence yet. I didn't see any trial on this level. With lithotripsy. Second, it is like in Belgium and I think in a lot of European countries not reimbursed, so it's going to add costs up to the ceiling if you want to combine it with a covered stent. And for me, the third argument is probably the most important. Would I consider to use an intravascular lithotripsy? It's when you have 360 degrees of calcium. So really a ring. And this was not the case on the transverse images of the scan. If I have 360 degrees, a full ring, then I think that there is really an indication to use intravascular lithotripsy, because I had cases where it was impossible with a balloon expandable stent to open the lesion because of the ring of calcium. If you can break it, soften it, modify it with the intravascular lithotripsy, that's my ultimate indication there. This was not the case, so the cheapest vessel prep is the best vessel prep. It's just plain old balloon angioplasty. And then afterwards, and that's the big discussion, of course, I think you need to stent it. The people worldwide saying that you only need to dilate this, I suppose they need to do another job. So here in these kind of lesions, calcified lesions, common iliac, ostium, all the arguments are there to implant a scaffold. The question is, of course, which scaffold? One thing. Second question, do we need to extend it in the aorta, and do we need to do a kissing configuration? You see that the other side, the left side, doesn't look that bad. It looks quite nice on the angiography. So I wouldn't jeopardize this, and I would keep it simple. It's a task A iliac lesion there, an uncovered stent, balloon expandable right at the ostium of the common iliac, so that you can do crossover in the future in this diseased vascular patient, and with an 8 millimeter uncovered stent, based on the data of the DISCOVER trial, showing no advantage of an uncovered stent over the covered stent. Based on the money, I'm more and more thinking on health economics, so it's less than half the price. And yeah, I mean, no evidence for me to do a kissing configuration there. So straightforward ballooning, and afterwards balloon expandable stent, uncovered stent, and that's it.
So this is great. Thank you both of them, because you see that the same case just resulted in two different solutions. I would like to change a question for you. In case the cardiologist who referred to Stefano the case ask you, I need to have room to pass through with a valve because I need to replace the valve, the aortic valve. So in that situation, your solution would have changed or still is the same for both of you? So you need to pass with a huge introducer sheath, and because you need a further treatment.
I never take in account the opinion of a cardiologist.
Yeah. That's another point.
No.
You know that
It's a joke.
Because I had a case like this, very similar, and I decided completely my strategy because of the need to pass through that.
Yeah, but wait a moment. At one point, you need to decide what is the goal of your treatment now. Is it creating a paved way for the cardiologist, or is it relieving the symptoms of the patient and helping the patient? So we can discuss this in a multidisciplinary approach. Probably he can do first his passage to the aortic valve, just dilate it, passing, and then afterwards I'm going to jump in and implant an uncovered balloon.
In the case it can't pass through the lesion.
Intravascular lithotripsy.
Okay.
If it is not
so
sufficient,
you have changed it.
No, if it's not sufficient
No.
with angioplasty, if I do an angioplasty up to 8-9 millimeter and he's still unable to pass, probably then you need to do
and
an
for you,
IVL.
Antonella?
For me, I think that a stent there is not a limit. At 8 millimeter stent,
It's not a limitation.
No, it's the 24 French. So all the valves, they are compatible. Now we have also the new valve. They are
We
very
need to discuss this because it's
absolutely.
clinical practice.
I think that it would not be a limit for them. Of course, would have been better to do it together at the same day, the valve and the stent, so they don't have to move along a stent that is actually just implanted. It can a little bit move. That is another thing. But if with some attention following the sheath while going up, I think there is not a limit, a stent.
I would like to have some other solution. Yes, please.
Here we are. The cardiologist.
Nice to see you, Cohen, my friend. So you triggered a little question, but I'm happy to answer. I think there are some studies for iliacs and IVL. There is also a study summarizing exact such cases prior to TAVI. And I think there was a cohort in the DISTRUCT-3 which also included a patient with celiac disease. Well, I think in this case, irrespective of the cardiology management, IVL may be the only case to avoid kissing stent, probably. So it may be an option to avoid kissing stent. But of course, there are some studies, but there is not so much randomized, actually no randomized evidence at this level.
Shall we
Thank you.
ask the audience?
Yep.
So who of you would just
we
perform
have-
the
No,
answer?
we will have
Afterwards, we have
Craig.
the slides with
You are
questions.
in advance. Thank
Guys,
you.
can I?
Thank you.
5 minutes, and we'll ask you.
Can I ask you guys a question? Would anyone? Can you make an argument? I wouldn't personally, but can anyone in the room make an argument for an aortic component to this, like a CIRAB? It strikes me as over-treatment, but I just wondered if there is anyone doing it and if they could convince us or the panel as to why that might be the best option. And if they wouldn't, that's fine.
Anyone for syrup? Okay, perfect. No
Okay.
one for syrup.
I will ask another
Yeah, but
Belgian guy there.
Yeah, I can. I
What
can
about your solution?
reply.
Who?
Michel.
Michel.
Well, it's an 8 millimeter iliac artery. So we know that we have to do, when we do IVL, we need to oversize. Still don't have the balloons or the IVL catheters in the largest size available in Europe. So I would go for a single stent, try to avoid. So I have to agree with my Belgian colleagues.
And August, I ask you.
Can I ask Antonella, like the big argument for a cover stent in an osteal lesion heavily calcified is just avoid rupture. But I'm not fully convinced that a cover stent at that position protects you about anything, because a rupture in a bifurcation is not usually saved by just a tiny cover stent at that stage.
Of course, if the rupture extends above, yes, it could be quite a bad situation, because we need to add something. And of course, a syrup would not be the best, because with a rupture we have cutters. And
I
it's not
don't
an
really
option.
believe that syrup
Yeah.
is a solution for
Yeah.
a rupture as well.
And also, I mean, guys, another thing, the ones like you, Kun, would have put like a single balloon mounted stand at the origin. Would you then use a balloon on the other side just to inflate, or you just do with a single stand? Because, I mean, this could be another thing. You avoid the kissing stand, but you do a stand at the balloon. What do you think?
Yeah, absolutely. So no balloon on the other side. I'm a vascular surgeon working in a poor country. I try to keep it as simple as possible. That's always my adagio during procedures. When you operate on these aortic bifurcations, you see the distance between both iliacs. It is a kind of a imagination that the plaque would jump in this situation from this common iliac on the right side up, jumping to the other side. That's bullshit.
Okay.
There are lesions, really aortic bifurcation lesions, but also with tremendous extension in the distal aorta, where this can happen. Then you need to do CRAP or kissing. But in this situation, if you keep your balloon expandable stent right at the ostium, there is no risk of jumping plaque to the other side.
Okay, so Emiliano.
Yeah. So now we move with the solution of Stefano, and,
Okay,
and then we have the voting.
Thank you. I will spoil the solution. So let's go on. We did also the gradient pressure to have any kind of assessment, of course, to check afterwards. We decided to do a vessel prep. That could be something else. So with the 8 millimeter IVL, as Michel said, we don't have the L6. We'll have in the next future up to 12 millimeters. So in this case, the nominal 8 millimeter was probably without any oversizing. That is recommended 10% in this case. My algorithm is to do 6 cycles and then do the first check. And then I decided to complete the other 4 cycles. This is the first angiogram after the 6 cycles. And yeah, we were happy that was not so bad. And of course, in this case, what to do? Is this really just a vessel prep to do something like Kuhn suggested, bare metal spot stand? That is a solution, and we could also use this kind of treatment as reducing the cost of the procedure and doing a spot stand in place of cobble stand. So this is the angiogram from above, because it's important to check the flow from above with a pigtail. So, and this is the flow. The angiogram show us sort of residual stenosis. Probably we can say probably much more than 30%, the ideal 30%. And if we check the angiogram with the RAW 5, so the right, we like to check, of course, at least 2 or 3 projections. So this is a LAO 40. And you can see the angiogram with another projection. So we were thinking what to do. If you check this angiogram, look at the position of the plaque. It is between the aorta and between the iliac. So it is not the proximal iliac. It is the very proximal common iliac. So in my eyes, it was the aortic bifurcation. Okay? So C-rub probably in my eyes is a bit too much. B-rub is but probably in my eyes, what to do in this case, if stand or not. This was the plaque, concentric plaque. This was the position of the plaque. Of course, on the left side, I told you with the left pulse, probably not more than 40%. These were the calcification. My ideal treatment was the kissing stand. And without IVL, probably the directly curved balloon expander kissing stand, because I like to land in a healthy zone, from healthy zone to healthy zone, because I can show you cases with the aortic rupture with a curved stand in the same position. So if you don't prep the vessel and you crack the calcium in the proximal landing zone, you risk the rupture. We cannot say if we use curved, you don't risk anything else. So without any vessel prep, I would do this treatment, probably with vessel prep, as Kuhn suggested, probably also a bare metal stand, a spot stand. But coming back to the case, I did multiple angiograms, good, but probably not ideal. I did a gradient pressure. The gradient pressure was 0 after the IVL. And then, which is the third metal assessment, the flow. So the flow from monophasic directly in the OR was biphasic. 1 day later, triphasic. So I'm telling you that I decide, of course, speaking probably 50 minutes with my colleagues, because we are collecting cases, but after probably 2 or 3 years, if you check dependency of this kind of patient without any scaffolding, you are trusting more in this kind of treatment. And we like to say that probably is useful to avoid to jeopardize an aortic bifurcation in young patient. So in every patient, I remember yesterday speaking with Bruno about the case to do it in the next days. He said, yeah, I can do the contralateral access because the patient has a kissing stand, the aortic bifurcation. So this is a problem for chronic patient to leave a stent in the aortic bifurcation, to do a kissing stent. So triphasic flow in the common external and common femoral. This is the 1 year follow-up. I did this case 1 year ago, and this is the triphasic up to the tibial artery bilaterally. So this was, of course, and I can show you a couple of slides at the end of the questions to show you our enrollments in 3 centers with more than 70 cases. But we are trusting this treatment. We are not saying that this is the gold standard, because we don't have, as he said, we have just published data about a subgroup of PET3 with procedural data, not 1 year or 2 years or 5 years follow-up. So we are collecting about 100 patients with more than 1 year main follow-up, and we are believing that probably this could be not an ideal IVL standalone treatment, but also something that could help in a vessel prep in this district. Thank you for your attention.
So thank you, and now we vote. We vote with 3 flags, because we should have a sum up of this case. And so the first question is site of treatment. Yellow, right, left, red, and bilateral, green. So please vote. Most yellow, some green.
Some green.
So right is decision. This is the
Teo, which is your decision? Thanos, yellow. Good.
Why?
Teo, with vessel prep or without vessel prep?
Sabine, have you chosen right?
No, it was bilateral. I think we also, like Maria said, we would also have gone for a bi-iliac covered stent implantation. Yeah, I mean, I think it's very much has to do what's your daily routine in the cath lab, how you approach. But I really love the IVL solution because it's really, I mean, to have saved the bifurcation for crossover maneuvers is just great in this young patient. I'm not sure that's the problem with the just one-sided stenting. I think so too, that from the very beginning that you would have to bring up the stent quite high into the aorta. I don't think with a one-sided stenting you would have saved the bifurcation for crossover maneuvers. It's actually more risky because people will try to do the crossover and then it's really risky to damage the stent and to push it forward. So this is actually why I prefer a bi-iliac stenting because you don't have the risk that somebody is trying it. But
you
anyway.
took a great point, and as Kuhn said, take it simple and easy. So the second question is regarding the vessel preparation. Yes, vessel preparation. Yes, standalone therapy, or no? Something mixed, mostly. I don't know.
Rafa?
Someone who's believing the standalone.
No preparation because I see all these discussions around iliac stents, but the results of iliac stents are excellent. I mean, covered or uncovered. So what are we trying to do with IVL? I mean, it's very costly in this location. If it's to put a stent anywhere in the end, I think it's completely useless. If it's to try a standalone therapy, why not? But the comparator is excellent.
Yeah, this
we know.
A remark from
we get to collect data.
Just a comment from my side. What I find surprising is vessel prep for me is the preparation for balloon angioplasty. And so, I mean, maybe IVL is changing this paradigm, but you actually didn't do any angioplasty after the IVL. Maybe that's not necessary in the iliacs, but as I've said, I think it's a little bit a different approach to vessel prep, what you have done here.
Okay, so the survey before the meeting was 50% yes or no, so I think we are still there. Third question is stenting or not? Yes, yellow, no, red, kissing, green. Mostly.
Thanos, why yes?
Yes, I think you picked up. Please.
Yeah, I would stent because there's decent evidence to suggest that I should be stenting. And the costly part of any procedure, especially to society and the patient, is the intervention. It's not just the use of whatever you're using over the next 5 minutes during your angioplasty, etc. It's what happens to the patient over the medium and the long term. And there's data to suggest that stenting is better. I'd be using vessel prep because I wanted to preserve my bifurcation and I'd only be stenting the right side. And for the surgeons here, it is crazy to think that we would be compromising when we're doing some form of bypass. We always want to do the best kind of bypass using the best tools, and we keep having these conversations about using suboptimal strategies for endovascular options or endovascular procedures such as this one.
Okay, thank you. Type of stent, bare or covered? Yellow, but there are still two red there. Theo, please comment on that.
You're provoking it.
So I have here the first author near me of COMPRA registry that showed actually that we have better trend regarding patency with the covered stent. So for several reasons, I would like to take covered stent. First, regarding the risk of any kind of rupture because of the severe calcifications. We see very, let's say, rare, but we see it. And the second, I think and I feel much better with the cover stent regarding patency, as I said, concerning the evidence that we have at the moment.
Can I add one thing? Guys, for all the young people in this room, if you want to stand that with a bare metal stent, always remember to have a cover stent on the side. Not open, but ready. Because if it really does an iliac rupture, it's very good to have the sheath already big enough in order to pass the cover stent, in my opinion, and also, to be ready to put it. Because an iliac rupture can be very quickly debilitating the patient.
And also the wire inside.
Exactly, why, of course.
Yeah, I just need to react on Theo. I mean, a registry with some trend to better patency, what a tralala is this? I mean, the DISCOVER trial is a head-to-head randomized trial in the common iliac, where it is clearly proven in a group of patients, randomized level 1A evidence, that there is no difference at all.
Okay, but this is a longer study than the COBRA registry, which is new one and has more data inside. That's the point.
I'm really looking forward to these data.
So type of stent, self-expandable or balloon mounted? Yes, this is the same result of the survey, balloon mounted for most of you. And how to assess results?
There's also IVUS, which no one mentioned. It was some US clinicians who say IVUS 100%. I mean, let's leave it aside. Just don't want to mention.
So, angiograms, gradient pressure, EVUS or IVUS?
No, it's different.
Yeah, I know,
I think also the different projections that
Yes,
Stefano mentioned
angiograms
are key. Because, I mean, if you don't really have an IVUS, which checks, all around, to do different projections, will really help you to understand. Because, I mean, for example, on I don't remember if LAO or RAO, it looked like the plaque completely disappeared. So, I mean, this is not true. The plaque is still there. It's not probably as prominent as before. Of course, it's like confirmed by the clinical symptoms of the patient, but the plaque is there. So, if you don't take two projections, you can be very easily, confused.
And we learned also that also the angiogram with different direction is with the injection is show us something different. So from below and from
use the pump from the aorta. Don't do it from the sheath. That's another thing.
Yeah.
Is there anyone who voted the survey before coming to London here in the room?
Come on, anyone who voted the survey?
Someone come here because there is a grant.
Is there anyone who voted online? Good.
Come on.
The people, come on the stage, please.
So I have to thank all of you because...
Come.
Yeah.
Everyone, please, everyone who voted.
Raise your hand. Yeah, there is another.
Have you voted?
Otherwise, he wins for sure.
Come. Only two, okay. There were roughly 100 votes, so we were pretty happy about the results. Only two, and no one else.
Please ask because this is your fault.
Okay. So, the question is, are you vascular surgeons or interventional radiologist? Or interventional cardiologist?
Hello.
Yeah.
Interventional angiologist.
Interventional radiologist. And you?
I'm a vascular surgeon.
Vascular surgeon. So, okay, this is a proper vascular surgical question, so it could be that, she could have an advantage. The question is pretty easy. What's the year of the first bypass done? The one who gets closer wins. Of course, if you know the date, even better. But
tell us a year. Year in the somewhere. You need to go closer.
I can help you.
1882.
1882. Okay. Wait a second. I will say 19. And let's say 19. 19 something. Let's rephrase it again. Let's get a bit closer.
1905.
19?
Then if I go in the 20th century, I think it's a bit later, 1939.
1939, and your final is?
War. End of the war, 1945.
1945! 1948! Very well done.
Alexis Carrel did the first bypass.
Exactly, Coulan, and it was
no,
someone.
sorry. Kulan.
Colin was this fellow or like a young physician of Leriche. Leriche left, he went for a trip for some teaching and he did the bypass. Leriche comes back and gets pissed because he did it. And essentially in his paper where he described the bypass, there's a long paragraph saying, thank you Leriche, who was not believing at all in a bypass. Thank you Leriche for the support and for believing, and it was all false because, you know, Leriche went very hard on him and it's like all times, hopefully something changed in the meantime, but anyway.
So tell him what...
So FWA grant for next year, 2025. Okay, so I think it's big clap.
Thanks a lot. Yeah.
So I thank all of you because it was nice.
And to be honest with you, you know what? We're going to grant also her a grant, both of you will get a grant.
So thank you, Antonella, thank you, Kun, because you saw a not simple case because doesn't exist a simple case, but a short lesion, no multivessel lesion, triggered a lot of discussion, and maybe we need more and more data. Thank you very much for
Thank you
staying
very
here.
much. Thank you, everyone.